pullover.
Yeah.
With a collar, that's pretty good. Okay, just a moment, please.
This conference will now be recorded.
You may begin the meeting. Thank you.
Good afternoon. Today is January 8th, 2021, and it is 2:06 p.m. And this is the Physician Assistant Policy Committee meeting. This is being broadcast publicly on the State Medical Board of Ohio's YouTube channel. I will now do a roll call. Scott Kackler.
Present.
Robert Zanger. Dr. Mehta.
Present.
Karen Conger.
Present.
Dr. Feibel.
Here.
Dr. Engel. And Kent Kulo. The minutes from the last meeting of this committee, which was held on October the 10th, 2020, have been sent to you for review and comment. Unless there are any questions or concerns, could I get a motion to approve the minutes from the October 9th, 2020 committee meeting as drafted?
This is Scott. I'll make a motion to approve.
Do you have a second, please?
Second. Dr. Feibel.
Anyone opposed? The minutes will stand as approved then. Thank you. We now get a legislative update from the Medical Board Legislative Director, Chelsea Wonsky.
Good afternoon, and thank you for allowing me to provide the legislative update before the Physician Assistant Policy Committee. The past month was extremely busy as the 133rd General Assembly wrapped up business for the year. There are a few bills that were passed that will have significant impact on the State Medical Board. The Medical Board staff is currently reviewing the impact of these bills on Medical Board operations and will be reporting back to you on what steps will be taken to institutionalize these new policies. Senate Bill 310 was the capital appropriations bill and also disperses federal COVID funds. The language in the as-passed version of the bill included amendments that waive supervision agreement requirements for physician assistants and advanced practice registered nurses, allowing those individuals the ability to work with physicians other than those with which they hold a supervision agreement. Additionally, the bill allows retired medical professionals to practice temporarily without reinstatement of their license during the pandemic. The language included a provision that excludes those whose license had been previously suspended, revoked, or surrendered to avoid disciplinary action. These provisions will be effective until May 1st, 2021, unless they are extended. House Bill 263 creates licensing opportunities for individuals with former criminal convictions. This language places limits on the board's ability to deny a license solely based on a prior criminal conviction. The new law requires that the board create an inclusive list of criminal offenses that would prevent someone from becoming licensed, and there are also new requirements for reporting to the Department of Administrative Services. House Bill 442, which initially applied only to certified public accountants, was amended late in the legislative process and removes Oriental medicine practitioners and cosmetic therapists from under the regulatory authority of the medical board. The amendment also reduced the education hour requirements for massage therapists, made changes to requirements for clinical research faculty certificates, and increase the number of volunteer hours that may be applied as continuing education credit for physicians. House Bill 404 was passed early in lame duck and extended many of the initial COVID-19 emergency measures. This included provisions that extend the license renewal requirement. Licensees that are set to require before April 1st now have until July 1st, 2021 to renew. Additionally, the language allows for a continuation of virtual meetings through July 1st. We continue to recommend that licensees renew at their regular schedule so that they don't forget to renew, and your renewal date remains the same regardless of when you renew. This concludes the legislative update. I'm happy to answer any questions.
Any questions for Chelsea? Thank you, Chelsea. And as she mentioned, we are internally reviewing any legislation that's been passed recently, and we'll continue to communicate any impact that it may have on any of the occupations that we license. Several sets of rules are due for their 5-year review in 2021, and some technical changes have been proposed. We sent those, I think, out to you last week when we sent you other material for this board meeting, and to give you a chance to review ahead of time. But I've asked Nate Smith, who is our senior legal counsel, to come on and just generally talk about some of the rules that we have pending.
Sure. Thank you, everyone. Kim Anderson provided a lot of really great detailed memos on this, and so I'm mainly going to work off of her memos. I can do this in the order that's on the agenda, starting with the comments on the weight loss rules. That starts on page 89 of your materials. Kim had drafted a memo that basically informs this committee that rules 4731-1104 and 4731-1104.1 are pending at CSI. There was a suggestion that the board consult with experts in obesity medicine to obtain additional comments. That meeting with experts was convened, and there are some additional materials that are provided, including the rules themselves, specifically the 11-04 and the 11-04.1 rules are at pages 102 to 109. So at this point, we would ask for the Physician Assistant Policy Committee, if you have any comments, to provide any comments to the board for consideration.
I guess I have a question. Looks like the expert panel convened November 23rd. Was there any changes at that December 9th board meeting that are different from this?
I believe that what occurred at the board meeting was that these rules were going to be circulated for additional comment. I don't believe there were any additional changes made, just that they were going to be circulated for additional comment.
And we continue to take comments, I think, after that board meeting, and I know that's something that Dr. Soin and Kim Anderson are both looking at from the experts that we have. Is there any other questions or concerns for Nate on the rules that we have pending?
No, I'd say the same thing that before, before it went to CSI. A lot of that expert stuff, I mean, that's the experts, and that's kind of out of the scope of this committee. But from a PA standpoint, if you're a PA in, or and this is your specialty, adding further restrictions to what they can do, to them in that specialty. That's kind of what the same feedback we gave last time.
Remind me what that feedback was, Scott, if you don't mind.
So if you and I are a PA, I'm a PA and I work with you and we do this, every time they come back, you initiate a treatment, I should be able to see them in return and, make adjustments, not start new. It does say that, but that you have to chart review and read everything, that we can't just have a discussion about a patient like we would for all of our other patients. Because the law, anything that's in our scope of practice is in your scope of practice, is in my scope of practice, and you can delegate to me. But there's parts of this where you have to be in-house and read all the chart reviews. Doesn't kind of match there.
From a PA standpoint, you'd rather that that this part of the rule be removed?
Yeah, I think it should match kind of the law says, is that we communicate, whether that's virtual, telehealth, telephone call, Zoom meeting, not, a formal chart review where you are coming and reviewing everything from a charting perspective. It meant you're specifically chart review. But if you're not at a computer, I can't just call you and say, hey, this patient has this. Can we make this adjustment? The way it's written, you got to go in and go to a chart review. And
This is the 11-04.1 rule. I believe it's B3 paragraph that you're speaking of.
What number is that?
11-04.1. On page 108 of your materials.
I think I'm there.
And I believe the paragraph you're speaking of, just interpreting as B3.
Well, I mean, the wording says following the visit. It doesn't say real time. So, I mean, I think it's fine. It says following each visit. It doesn't say it has to be reviewed in real time.
Yeah, it does say that. Does that change how you feel about it, Scott, by chance?
Look at that and
sorry, I'm muted. I was muted. So does that go back then to the quality law that we just have to review charts regularly, twice annually in your first few years and then annually thereafter? I mean, is that what that means, or is that more restrictive?
No, it has to be following each visit.
Yeah, I would read that as more restrictive than that. But it's not in real time.
are you okay with that, or do you need us to do some more follow-up with you after this on it?
Are you talking to me or Scott?
Any comments or concerns about any of the rules that Nate talked about that you've reviewed? Just as a point of note, if we're moving on here, I wanted to let you know, I know you get emails and phone calls and communications from Sierra Lynch, who's been our stakeholder liaison for the past year. She's leaving us next week for a new career opportunity, and I just wanted to say that we thoroughly enjoyed working with her and that we wish her continued success personally and professionally as she moves on in the future. And as we get new staff, we'll make sure that we let you know about that. This committee is not going to be until April 9th. In the meantime, if you have any questions or concerns, always please feel free to reach out to me or anyone else, obviously, on the medical board staff. Concerns or questions or comments that anybody has regarding anything to do with the committee?
Jill, I believe we only got through the first of the three different sections of the rules. I just want to make sure that everyone has an opportunity to give comments on the other two sections.
Sorry, Nate.
Well, no, that's okay. I think we had a little discussion.
Yeah.
It's good.
Scott, I just want to make sure before we move on, you're okay with how this is written now?
Well, I think there's still a lot outside of the scope of this pertains to PAs. I mean, that was my only thing from PA perspective.
But this statement that says a physician assistant shall not initiate utilization of a different controlled substance in Rexer, but may recommend such change.
I'm okay with that.
And
I mean, if it's in that realm of, I mean, that's all you do with if it's could be delegated to you, and now I still think that's confusing for the PA out there practicing and the physician, if the physician is, supervising a PA.
Well, it's just requiring them to, as opposed to just a phone call saying, hey, I did this, they actually need to look at things. And I think they want a little more guardrails. I mean, I think the idea of this is a little more guardrails on the specific substances, just to make sure they're being prescribed correctly. And it doesn't prohibit you from doing it. It just says you got to then review physician assistant.
I understand.
Prescribing the other doctor. Okay. Good.
There are no more comments on the weight loss rules. I will go ahead and move on to the second item of the agenda, which is I believe the initial circulation of rules. This is a whole host of rules covering a variety of different areas. So this starts on page 1 of your materials. Again, Kim Anderson has included a very comprehensive memo of what is here. I will say that the first 2 rules, 4731 1-12 and 4731 1-16, are massage therapy rules that are still in the process of being formulated. There's been some additional input. So I'd like to remove those rules from consideration for comment today. But the rest of the rules, and I can just quickly walk through them, are basically provided for the PAPC to provide any comments to share with the board on. So many of these are no change rules. So 4731-1108, prescribing to self and family, this is proposed as a no change. There are some minor edits on 4731-14-01, pronouncement of death, that reflects statutory changes. In addition, there are no change for 4731-2301, as well as 2303 and 2304. There are some, Kim speaks about reaching out to DODD for some comments on the 23-02 rule. And then the 4731-26 rules are sexual misconduct rules. And there are some changes relating to adding and deleting license types and changing to license from certificates. So at this point, would like to open up for comment on any of these rules that any members of the committee would have comments on that we could share with the board in the future.
I'm guessing in 4731-1108, where it says physician, it also means PA. I mean, we've done this in the past where, like, the pain rules, the chronic pain rules, or acute pain rules, where it says physician and a PA is applied.
I will confer with Kim about that, but we can definitely get back to you for sure on that. But yeah, I'm aware of that
Which page you on?
situation where it's been interpreted to include both. But
it's more just a general, it's a general comment that, sometimes in these rules, like chronic pain rules, we did those a long time ago. When we say physician in those kind of rules, they'll say it also implies the PA. But now, as we're doing other rules, we're spelling out PA, so then it can be confusing. Someone reading the rules, when does physician mean me and when does physician not mean me?
Yeah, that should be clarified, because I would not read that. If I saw it as physician, I would not read it as physician or PA.
Right, but when we reviewed the chronic pain rules and all those things in the years past, it's always been, if it says physician, then it means because of the delegation authority that it also means that this includes the PA as well, that you're delegating that.
I think those are good things to clean up as they come through.
Right, that's why I was saying it's just a general comment. I think that rule should apply to PAs too.
Okay, I will take note of that comment. Any other comments?
I appreciate that, because the ambiguity is never good. It's one of my big beefs about the board. I always want to make sure that we're very clear to our licensees about exactly what we expect. And then I think we can hold them to account. I think it's important to be very clear about what we're expecting.
Okay. Sounds good. If there are no more comments on those initial circulation rules, I will move on to the last group of rules, which are the proposed changes to the light-based medical devices. This will, in your board materials or in your PAPC materials, this will start on page 20 of those materials. Again, Kim has laid out a memo, and she's also included a prior board memo on page 21 through 24, I believe. The main changes that are proposed deal with physician assistants, and there were changes relating to training, on-site supervision, and the number of PAs that may be supervised by a physician. There were, in the previous version of the rules, I believe, there were a lot of details spelled out on that as regards to PAs. There has been a change in that regard where instead of spelling out a certain number of procedures or a certain number of PAs that may be supervised, the major change is that it references that the authorization must meet the requirements of 4730.21. So that is in response to some comments related to physician assistants. So,
which page are you on, Nathan?
The light-based rules start on page. The memo starts on page 20. The major changes to the rules themselves, the actual draft of the rules, would start on page 26 through, I believe, 32, 33. And the changes you will see are highlighted in yellow. And many of the changes are very similar in the sense that they're referencing the requirements of RC 4730.21 as sort of where the, I guess, guardrails on this practice are for physician assistants. Any comments as to?
So I took away the specificities and just used that as a generic guardrail then.
I think that that statute provides the guardrails, and so it was determined that that was the better way to go.
But it still has the in requirement, though, correct?
I'm sorry, I didn't hear you.
Requirements for the PA to do it, it removed that and referred to the other code. But the physician has to be in-house, correct?
I believe that
3 and 4. So like for 3 and 4, the physician is seen, evaluated in person, following each treatment, responded to the application. The other piece, as far as the procedure numbers and stuff, was removed.
Yes, are you speaking on 18-03?
Yes, A3 and 4.
Okay. And your comment was what on those hearings?
I mean, that's kind of like that in-person. So let me read. So it says, patient in person to determine whether the proposed is appropriate and how they responded to the treatment and things. I mean, I still think that is that create confusion for these, because when you're referring back to the other code where it says they can delegate that, but now this is in person. So the other thing says, in some way of correspondence, whether it's telehealth or phone calls and things, like I understand the purpose of it. I'm just saying it can create confusion too. I can see it creating confusion. Like I'm not talking about like the safety of lasers or anything like that. That's not my expertise. I'm just talking about where kind of it talks about the physician seeing them in person, where in a regular practice that is not in standard or the law, right?
Where are you again referencing? I'm sorry.
So I mean, they're all kind of 4731,
21?
all A3s and 4s.
In actual 4730-.21?
18.3 is the one I'm actually looking at. 4731, 18.3, A, 3, and 4.
I believe it's on page 27 of the materials.
Page 27, correct. I mean, the same language then is used for, the next one down for hair removal. B3, B4. I mean, they added in person. I mean, at the time of this pandemic, does that need to be in person? If they can delegate everything to a PA, is that something we could do telehealth or? So for like a hair removal, in my world, I relate everything back to my world. So and I think I gave this example before, if an ENT surgeon refers someone to a plastic surgeon and says, we're going to take the lab and put it in their mouth to reconstruct their mouth. They need the hair removed from their forearm. That's going to be 6 visits, 3 treatments, but 6 visits now for that patient. They'll have to see the physician to approve the hair removal, come see the PA for their first treatment, go back to the physician, see how they responded, go back to the PA for the second treatment. Because they're not in person, they're not in the same building at the same time, typically, unless we change the route of practice.
Well, they can see the physician by telemedicine.
But added in person. That's my that's my question. Can it be telemedicine? Can it be a consultation virtually
With the physician?
Correct. So they get their
Isn't it just implied by the governor's the last ruling, like that just came through, that telemedicine is sort of allowed?
But I think that's not a permanent law, though.
Yeah, it's
Right.
not permanent law, and I'm not sure, Nate. This is something we probably should address in the. I mean, I don't mean to digress, but it's a good point that we should probably reference this in the telehealth bill when it ultimately comes through. Is that where it says a physician or PA should see the patient in person, as long as they're following the telehealth rules, telehealth will qualify for in person. Is that possible?
I think, I guess just to clarify a couple things, what the governor's, there are a lot of sort of temporary authorizations out there allowing people to do things by telehealth. There were a couple different bills that were moving through the legislature in the last General Assembly that were trying to make some of these, I guess, more lenient policies towards telehealth or expansion of telehealth. We're trying to make them permanent law. Those did not pass. There are likely to be additional bills introduced into the next General Assembly. So I think we'll have to follow sort of where this goes in terms of if there is an expansion of telehealth sort of post-pandemic. But I think the rules are written sort of as a, looking forward post-pandemic for the next 5 years.
Yeah, but I would not want to put telehealth in there and give if it's not statutorily allowed, and we don't have statutory approval for it yet. So it's one of the things you have to remind me about when we go through. I'm chair of the telehealth committee for the board, so we go through the telehealth stuff. We should make sure that we put in there the purpose of the rules. I don't know how you do this, but something that in person is equivalent to telehealth as long as you're following the law of the telehealth bill. So as long as you've seen the patient before and everything else, I think in-person or telehealth would be synonymous with rules. Would that cover us? If the statute said that, then the rules would, when it says in the rules, a physician would see the patient in person, it would cover telehealth and in person both. I think that's the proper way to do it rather than the other way.
Yeah, I agree with Dr. Feibel. Yeah, the way you're wording it, that in-person or telehealth.
But I don't think we should put telehealth in here, because if the statute doesn't pass, then it would not be, then the statute trumps the rule. And we would be kind of inducing people to break the law.
Well, that's why I was consultation. I mean, is there another word you could use there? I mean, in our roles, it's delegation after, some kind of you can communicate one way. I don't know what the actual words are in that, but
yeah, I know Dr. Bechtel is much more in tune with the light-based therapy rules than I am, and I don't know whether he would have objection to that. We can certainly run that by him and ask if he, because I think that the idea of this is that they did want the physician to observe this on a in-between basis, whether it be via telehealth or in person. And unfortunately, since telehealth isn't, I mean, I know this for the pandemic, but otherwise telehealth is not a real statutory thing at this point. I'd hate to put it in the rule when statutorily we might not be.
That's why I was recommending something else like communication. So if the patient's coming to see me for their second treatment of their hair removal, and I use our UpDocs and show you a picture of the forearm, and it's going well, and your plan was to give 3 treatments at XYZ dose, it saves that patient an extra trip. I mean, that's the same thing as our laws. We have to communicate about all patients and interventions.
So the way I read 3 and 4 is it's before the treatment starts and then after the first initial application. So you're talking about 2 in-person encounters with the physician. If the person would have subsequent treatments with the same vascular laser, I don't read 4 to require additional physician in-person visits.
Even though it says, but prior to any treatments, following the initial application, but prior to any consultation treatments. So you're just saying your interpretation of that's just the first 2, not 3 and 4. I mean, if the intention is it would be, I would think it would be every single one. But I don't know. Yeah.
I guess I'm reading the first phrase. The physician has seen and evaluated the patient in person following the initial application, meaning the first application. But before you would do any additional applications, before any continuation of treatment, in order to determine that the patient responded well to that first application. But it's using that specific type of vascular laser. If you would switch to another type of vascular laser, then you would again be subject to 3 and 4 again. Is the person
right? It's the same as the weight loss. We're not changing treatment. If the plan was X, you do 3 treatments of this. The way I was reading it is that they got to come back and see in person each time. But now, what your interpretation is? So if the attending sees them, says they give them 3 treatments. You give them a treatment, they come back in the room after treatment and check it, then, because there's no time based on this, right?
I got to tell you, as I read this is pretty ambiguous to me, because I would have read it the same way Scott did, where it says, but prior to any continuation of treatment, anytime you continue treatment, you'd probably need, based on this, the physician to see it. Now, I don't know if that's the intent of this or not. Again, I'm not as familiar with the laser-based treatments to opine about. It's something we can certainly take back to the board and ask.
Yeah.
Well, it is. I think it is intended to have subsequent evaluation by physicians, right? Because that was one of the things. So, because one of the concerns from Cleveland Clinic and was that they didn't want any delegation to any PAs, but this was a way to provide the extra guardrail, but at the same time allow the PAs to perform laser treatments. Because if you look at the letters from Cleveland Clinic, they didn't want anybody delegated for laser-based treatments.
We can take this comment back to the board and see if they believe that A4 should be clarified. I think the intent was following the initial treatment, but we can certainly see if there could be some language to clarify that. So that's a comment that we'll take back to the board.
Yeah, and I don't have a problem. My question is around the in-person and can it be, can it just be the communication, and whether that's a picture or, an UpDocs telehealth type thing? Does it really have to be in person? Because we're not really in the same place at the same time anymore. It's just the way it works.
Okay. Well, I will.
One of the things that might be the board may be worried about a little bit, is that that's shown to the physician ahead of time versus, oh, by the way, this patient came in today. Let me show you a picture, and this is what I did, type of thing. And so if the patient has to be actually seen by the physician, either via telehealth or in-person visit, there's no way to alter that plan at all. Because I could see that happening, unfortunately.
You could say real-time communication. You could put a time parameter to that, but the way you interpreted it as then, I think the attending could technically see them, say the plan is 3 treatments, they get a treatment, they see them post and never see them again, right? That defeats the purpose of what you're saying too, with the way it's written. If you see it right after the treatment, you're technically seeing them after the first treatment, but before subsequent treatment. But I don't think that's the intent of the way it's written. Does that make sense?
I think we should provide these comments to the board that, both the telehealth aspect to it, and that you believe that the wording of 4 is not particularly clear.
Yeah.
Any other comments?
I think it is clear, right? That's the intent. That was one of the ways to appease one of the stakeholders whose concern was not to delegate. This was to make sure that PAs are allowed, but at the same time there is guardrails.
Yeah,
I think the not clear part was, is it after the 3rd treatment and the second? Does the 3rd and 4th treatment need in person? That's the way I interpret it, but that's not the way you just read it off.
So Nate, there's clearly some ambiguity because Scott's reading it one way and Nate's reading another. So anytime that happens, I'm always in favor of trying to clear up any ambiguity again. So for reviewing the rule, it should be an easy thing to clear up between each treatment versus between the first treatment. Just put it in there one way or the other.
All subsequent treatments, right?
Yeah.
Okay.
That's 4731-18-03, number 4, right?
But the number 4 is repeated in multiple different things. So it's under hair, it's under non-vascular. It's repeated a couple times. And it may be different for them. Again, I'm not talking about the actual laser. I'll defer that to the experts. My concern was more about what's the operationalization of that from a PA perspective.
Again, I don't know what they were trying to provide here, so we'll think about it. Thank you for the comments.
Thank you for the feedback. If that's all the comments, I'll turn it back over to Jill.
Thank you, Scott. The next meeting that we're going to have is in April, and I'm assuming that it'll still be remote. In the meantime, obviously, if you have any questions, then we will get back with you and get clarification on the points you brought up, and get some comments back from the board as well. Is there any other business that needs to come before the committee today?
Any update on the PA, kind of the detox rules? I think we talked about it last time. The consult agreements with the pharmacists.
I believe those PA consult agreement rules are in the rulemaking process. I'm not aware of any, actually trying to look at the board's website right now to find out where they are in the process. So if you,
I think they were talked about in November, the policy.
We got filed with CSI, but I'm not 100% sure.
The detox rules, the whole PA rules. Or were they one and the same, maybe?
I think they were when they were on the agenda in October when we talked about them, they just said kind of similar to what I alluded to earlier, that the PAs would match the physician, but it wasn't clear as were they going to spell out PA or were they just say when it says physician, it means PA. Provider.
and that's the detox rule you were interested in?
So the detox rules and the consult agreement with the delegation to pharmacist for adjustments on medications.
Okay. We can get back to you as to what the status of those are.
Yeah, we'll look into it, Scott, and email you and let you know what the status is.
Thank you.
You're welcome. Anything else to come before the committee? Then if not, could I get a motion to adjourn?
Motion.
Then a second, please.
Second.
And then all of those in favor?
Yes.
Yep.
All right. We're hereby adjourned. Thank you so much for your time this afternoon. And Scott, we will get
This
back.
conference is no longer being recorded.
All right.
All right. Thank you.
Have a good weekend.
Thank you.
Thank you.
Weekend.
You too.
Thank you, as always.